And I'm happy to introduce our next speaker. It is Dr. Slobodan Antov, and he's going to talk about, and the talk is about complications in mesenteric artery procedures.
I will try to first to thank you for this invitation and this opportunity to show this particular case and methods. And I will try to say something somewhere in between, because between head and below the knee. My presentation will be for transradial approach for stenting of occluded mesenteric artery. It was more compatible with previous session in the morning. I do not have any potential conflict of interest, and if I, as interventional cardiologist for 38 years, 5 last years I am working in private hospital where a lot of complex surgery procedures are doing every day, and complex vascular procedures, and no new field for conquiring appear to me, and I try to stick to the abdominal surgery and blood vessel complications, as is mesenteric artery ischemia. When intestines do not receive enough oxygen-rich blood, it can lead to cell death, permanent damage, and even can be life-threatening procedures. There is two types of mesenteric arterial ischemia: acute, more connected with thrombosis, and chronic, more connected with atherosclerosis. First one appears suddenly with severe symptoms, and second one has more gradual onset. Symptoms are well known as abdominal pain, sense of fullness, diarrhea, nausea, vomiting, fever, stomach pain that can be lead for weight loss, and diagnosis can be done with physical examination, CT scan, ultrasound, MRI angiography, and arteriogram. The treatment: acute mesenteric artery ischemia need immediately treatment, prevention of tissue because of a need to prevent tissue death. Chronic mesenteric artery ischemia sometimes needs surgical treatment because of damage of the bowels, but the main way to treat this disease for me is angioplasty and stenting, and that is desirable treatment of acute and chronic mesenteric artery ischemia. Also, additional medications are needed as antibiotics, anticoagulants, vasodilators, and certainly changing of lifestyle. Prognosis of chronic mesenteric artery ischemia is good, they recover well, but acute mesenteric artery ischemia has a higher morbidity and mortality. Prompt treatment is imperative for good prognosis of mesenteric artery ischemia. I would not explain a lot of recommendation in guidelines, but some meta-analysis from 2016 and 17 make interventional treatment to become more acceptable for this disease. And from class 1 level C, stenting get in 2024, as previous colleagues mentioned, 1B classification. These meta-analyses are published in European Journal of Vascular and Endovascular Surgery in 2016 and 17, and meta-analysis is of mortality after open and endovascular revascularization, and in total, this meta-analysis, another one for bowel resection rates after open and endovascular therapy, and 30 days mortality rates after open and endovascular therapy of mesenteric arterial ischemia, shows advantages of endovascular treatment. And I will jump to clinical history of 42 years old female patient, which was presented with stomach pain, nausea, and vomiting, which progressed with clinical symptoms of ileus. Symptoms appeared a few days before admission, and on the day of admission, symptoms are strong, intense, and there was sudden deterioration. CT scan was performed, which showed occlusion of upper mesenteric artery. The upper mesenteric artery could not be visualized by angio. Immediately, patient was transferred to surgery, and the same where the artery bypass was performed. Within next few days, symptoms stay almost the same, with but less intense. After 15 days of discharge, patient was re-hospitalized because of pain, nausea, vomiting, weight loss, dehydration, and symptoms of intoxication. New CT showed occlusion of upper mesenteric artery and previously performed bypass, and patient was transferred to our department. This is the first scan. I will try to run through both interventions. First one is diagnostic. We do transradial approach, 6 in 5 range, slender hydrophilic introducer, and this is catheters that we use. Judkins left, Judkins right, and Amplatz right. Coronary angio showed that there is no coronary artery disease. We diagnosed bilateral dual renal arteries, and there is no sign of superior mesenteric artery, which cannot be cannulated. Patient was immediately sent to bypass surgery. After this, I will show you, run through the interventional procedure. This is pre-procedural forearm angio that we perform. Right coronary artery without disease, left coronary artery without disease. And this is orthography, which show us same findings. Celiac artery branches, planic, hepatic, and gastric are potent, normal. And I give name to this angio, inspired by one song from Creedence Clearwater Revival, Running Through the Jungle. Or it's like driving a bumping car in aorta. Colleague cannot be patient and to try to find the origin of the mesenteric artery. And after that, he sent the patient to surgery. This is second CT, which show us same findings. And mesenteric angiography show us occlusion of superior mesenteric artery and angiography no size for visible aortomesenteric bypass. Second intervention was done through same radial artery, same slender hydrophilic introducer. We use guiding catheter Amplatz right 2, BMW Warhorse wire 10014. We pre-dilated with balloon 2.020, 2.5, 3.0, 3.5, 30 millimeters on 14 atmospheres. And after informing the patient that we will use off-label coronary stent for stenting the mesenteric artery, and we get confirmation. We proceed with stenting with drug-eluting stent, Synergy 4.038 millimeters on 18 atmospheres up to 24 atmospheres. Control mesenteric angiography show us optimal result after stenting, and you can appreciate the same transradial artery, little bit more spasm this time. And this is what it's left for occluded superior mesenteric artery. After we cross the occlusion, we start with pre-dilatation, and because we are not comfortable on this field, we step by step pre-dilate the vessel because we have no experience with abdominal vessels. We have experience with coronary one. This is second pre-dilatation with 2.0. We take longer, check the carina. Also on this slide, you can judge about function of the one renal. This is third pre-dilatation, fourth one. We increase size of the balloons in diameter, and this is stent implantation after rechecking of the positioning. You can follow the stent opening, and you can appreciate little waste in the stent deployment, what make us to do after stent view post dilatation on 24 atmospheres. This is the final result, and another position for checking the carina between aorta and mesenteric artery. 4 days after intervention, the patient is dismissed without any symptoms with prescribed therapy, aspirin, clopidogrel and rosuvastatin in proper doses, and we perform 7 months angiographic unfaithful symptom-free follow-up with venous phase, with BSA, and we can conclude it that stenting of the superior mesenteric artery as a method of treatment might be a solution of vascular post-surgical complication and could be used as a bailout strategy or an alternative to surgical treatment. Transradial approach is safe, less traumatic, and more feasible for stenting of superior mesenteric artery in comparison with surgical treatment. And thank you. I will finish with to provocate discussion with one question for the audience and chairpersons. When patient can start with eating?
When you were successful, then you can start eating the next day.
Even I was so experienced, because I was happy of the result of the intervention, she said to me, I feel rumors in my stomach. When can I eat? I said, you can eat immediately. And that cost me 24 hours more without sleeping. Because I don't know if there is any damage.
Yes, question, please.
Just as a comment, the eating, it depends on the surgery team. I mean, our surgeons in those situations usually prefer 24 to 48 hours waiting time just to see what will happen with the intestines, if there is a necrosis or something like that. And then they permit patients to eat, and during that time, their own parenteral eating.
Yes, thank you for advice. I hope that I learned my lesson well.
Okay, are there other questions? You have one.
It's a relatively simple question, but according to the previous talks about the stroke and STEMI, what is, on your feeling, the time window for intervention? When it's too late for acute mesenteric?
I will prefer individually patient approach. If there is still good signs from patient side, you can even 24 hours after event, you can well plan and go to do intervention. And in the case of question from lady, chairpersons, to Dr. Klaus Matthias. I will ask them which kind of stent you will use if there is active plaque 78, 80%, as it was mentioned. Which type of stent you will use?
I would use a balloon expandable stent, place it very precisely so it's not protruding too much into the aorta, and a stent with small mesh size, so you have not too much protrusion of plaque material, which might embolize into the periphery and might cause.
No, I'm asking about carotids. Which kind of stent you will use for that question from your colleague, your girlfriend?
Yes, my girlfriend. Yes. As I told you, yes, it's the same. Use a stent. Here we use a.
My question is, there is double mesh
expandable stent.
Road saver stent.
Road saver, for example. And because it's also with small meshes, we have these hybrid stents today. Yes. In former times, we had only. When I started that, I used the wall stent because also the cell size is fairly small with the wall stent. But today we have better devices.
Thank you.
So I would not only look at the stent, but I would look at the stent delivery system, because it is known that any pre-dilatation is a big risk of causing emboli. So if you have a stent delivery system that has a very big olive, or originally even one that was a delta, that is something I would not want to use if I then need to do pre-dilatation. So first thing that needs to be looked at, and then the question is always, which situation are we looking at? I would never, ever, in the acute phase, use a road saver stent, because they seem to be more thrombogenic in the acute phase, and the reported rates of acute stent thrombosis have been up to 30% acute stent thrombosis on the table, because the patients are not prepared in advance.
It's better with C-guard then.
It's not so. A very big differentiation. So it's not that all dual layer stents are the same. So there's a big difference between the C-guard with the membrane and the road saver or Casper stent, as it's called.
And which one you will use?
In which scenario?
In this one, 80%, no need for pre-dilatation, no need for post-dilatation, catch material toward the vessel wall, and not allowed to go downstream.
Yes.
Which kind?
I would choose between two different ones, either the C-guard stent, although I do not like the delivery system of needing 6 French system for it. The wall stent is still a good stent. Yeah, I quite like the wall stent, although we need to know that it shortens by 30 degrees, by 30%, 30%, and we do not know where it's going to shorten. So that's where I would make it. But what I do like about the road saver in a non-emergency situation, it's very flexible. So very, very flexible. So it works. So my rule is we have a couple of stents available in case of an underlying dissection or in the acute phase. Yeah, if you need a long stent, I use the wall stent. In a non-emergent stenting, I quite like the C-guard as a stent.
Thank you.
And with self-expanding stents, also release them very slowly. When you do it very fast, then it's jumping forward.
They will jump forward. Yes.
So, yes, now you have the closing remarks.
No,
we go on. So, thank you very much for your talk.